and Industrial Linkage Center of Excellence Universiti Selangor. Para ceramah undangan yang dihormati, Rizky Novera Yenita, Direktur 1 Institut Kesihatan dan Teknologi Syirah, Pekanbaru Indonesia, dan Dr. Wong Lin Hui, Pakar Patologi Klinikal, Ketua Jabatan Patologi Sri Aman 2 Sarawak, Pengarah Program Saudara Awang Nuraini bin Awang Mat Yasin, para pensyarah, penyelidik, dan para pelajar, para peserta, para penaja serta semua hadirin yang mengikuti siaran secara langsung melalui Facebook Live. Bagi pihak kehadiran tuan-tuan dan puan-puan CIS 2026, sebagai kolloquium ini menjadi medan perkongsian ilmu, percambahan idea serta mengeratkan lagi jaringan kerjasama dalam bidang sains kesihatan.
A very good morning. Our guest of honor, Associate Professor Dr. Nur Shafizah Ahmad Syukur, Director of the Center for Research and Industrial Linkage, Center of Excellence, Universiti Selangor. Our distinguished keynote speaker, Dr. Rizky Novera Yenita, Vice Rector 1 from Institute of Health and Technology Al-Insyirah, Pekanbaru, Indonesia, and Dr. Wong Lin Hui, Clinical Pathologist, Head of Pathology Department from Hospital Sri Aman 2 Sarawak. Our respected Program Director, Mr. Awang Nuraini bin Awang Mat Yasin, distinguished academicians, researchers, presenters, students, participants, sponsors, and everyone joining us via Facebook Live. On behalf of the Faculty of Health Sciences, Universiti Selangor, it is my pleasure to welcome all of you to the 21st Undergraduate Colloquium on Health Sciences UCSH 2026. Thank you for taking the time to spend your morning with us. We hope this colloquium will serve as a meaningful platform for knowledge sharing, scholarly exchange, and future collaboration in the field of health sciences.
Hadirin yang dihormati, Undergraduate Colloquium of Health Sciences merupakan program akademik tahunan yang menghubungkan pelajar, penyelidik dan ahli akademik bagi berkongsi hasil penyelidikan health through science. Tema ini menekankan kepentingan pendidikan saintifik, keselamatan dalam usaha meningkatkan.
Distinguished guests, ladies and gentlemen, the Undergraduate Colloquium on Health Sciences 2026 is an annual academic platform that brings together students, researchers, and academics to showcase research findings and foster a culture of research in health sciences. This year's colloquium is proudly held under the theme Advancing Health Through Science, Safety, and Sustainability. The theme highlights the importance of scientific research, patient safety, and sustainability in advancing healthcare and improving community well-being.
Antara objektif penganjuran kolokvium ini adalah menyediakan platform kepada pelajar prasiswaza untuk menginovasi. Semoga penganjuran kolokvium ini memberi manfaat kepada semua peserta dan menjadi pemangkin kepada kecemasan.
The objectives of today's colloquium are to provide undergraduate students with a platform to present their research, promote scholarly discussion, strengthen academic collaboration, and cultivate a culture of research and innovation. We hope today's colloquium will inspire meaningful discussions and encourage future research excellence among our participants.
Hadirin sekalian, sebagai tanda penghormatan, majlis akan dimulakan dengan nyanyian lagu negaraku.
Ladies and gentlemen, as a mark of respect, we will begin with the singing of the national anthem Negaraku, followed by the Selangor state anthem. Terima kasih. Bagi memohon keberatan agar majlis berjalan dengan lancar, majlis diteruskan dengan bacaan. Thank you. To seek blessings for today's program, we will now have the dua recital. It is our pleasure to invite Mr. Ilham Shahmi bin Isham to lead the recital.
Al-Fatihah. Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin. Wassalatu wassalamu ala salid wa alamin. Ya Allah, Ya Rahman, Ya Rahim. Kami merafakkan setinggi-tinggi 21st Undergraduate Colloquium. Ya Allah, jadikanlah pertemuan ilmiah ini sebagai satu majlis yang Engkau redai. Limpahkanlah keberkatan, ketenangan dan panel jemputan, pensyarah, mahasiswa serta semua peserta yang hadir. Ya Allah yang Maha Mengetahui, Quran dalam serta ilham yang membawa manfaat kepada agama, masyarakat, negara dan seluruh umat manusia. Ya Allah, bimbinglah segera meningkatkan keselamatan masyarakat serta memupuk amalan keharian demi kesejahteraan generasi masa hadapan. Ya Allah, permudahkanlah hati-hati kami dalam semangat kerjasama, saling menghormati dan saling berkongsi ilmu, ikhlasan, serta lindungilah kami daripada segala musibah, penyakit, kemalangan dan perkara-perkara yang tidak diingini. Bajikan dan jadikanlah ilmu yang diperoleh pada hari ini sebagai ilmu yang memberi manfaat berpanjangan. Rabbana atina fid
Terima kasih diucapkan kepada saudara Ilham Shahmi bin Isham. Teruskan dengan ucapan alu-aluan oleh pengarah program. Dengan sukacitanya, majlis mempersirakan saudara Awang Nuraimi bin Awang Mat Yassin, pengarah program.
Thank you. Ladies and gentlemen, it is now time for the welcoming address by our program director. It's a pleasure to invite Mr. Awang Nuraimi bin Awang Mat Yassin, program director of the 21st Undergraduate Colloquium on Health Sciences UCHS 2026 to deliver his welcoming address. Please welcome Mr. Awang Nuraimi bin Awang Mat Yassin.
Assalamualaikum warahmatullahi wabarakatuh and a very good morning everyone. To our respected Dean of Faculty of Health Science, Mr. Muhammad Syariq dari Mahad, our dear lecturers, invite speakers, fellow students and all viewers joining us live on Facebook. Welcome to the 21st Undergraduate Colloquium on Health Science 2026. First of all, I would like to thank the Faculty of Health Science and our lecturers, especially our program advisor, Associate Prof. Dr. Mariela Narapan Maniam, Dr. Muhammad Nazif bin Samad alias Darawi, and Mr. Aiman Afif bin Roslan for giving us, the scientific communication student, the opportunity to organize this program as part of our course project. Alhamdulillah, today we are gathered here virtually for a meaningful event that not only allows students to share their research project but also to gain experience in organizing a formal academic program and a strengthening teamwork among us. As most of you know, this event is a core part of our Scientific Communication MLS 3243 course, moving from writing manuscript and designing poster to actually running a live professional program has given us a real taste of what goes on behind the scene of an academic event. This year, we chose the theme Advancing Health Through Science, Safety and Sustainability. We want a theme that highlights how vital scientific research, strict safety practice, and sustainable ideas are when it comes to protecting public health and safeguarding our future. Through this event, we hope to build our confidence as presenters, learn what it takes to manage an academic program, and most importantly, create a space where students, lecturers, and guests can openly trade ideas and insights. On behalf of the committee, I want to say a huge thank you to our invite speakers, Dr. Rizky, Novera Yenita, and Dr. Wong Lin Hui. Thank you so much for joining us today and for being so willing to share your expertise with us. To our lecturers, faculty management, and my fellow committee members, thank you for your endless support. Navigating the glitch and challenge of planning an online event was not easy, but your teamwork made today possible. To all the students, especially our presenters, the research you are presenting today represents weeks of hard work, so be proud of it. Use this platform to share your findings, take in the feedback, and connect with your peers. It is incredible. Practice for whatever career you choose next. Before I end, I hope that everyone will gain new knowledge from today's program, and hopefully this event will inspire us to continue contributing to the field of earth science for the benefit of the community and the future. Thank you again to everyone who support this colloquium. I hope everything runs smoothly. I wish you all a fantastic, memorable event ahead. Thank you very much and Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih diucapkan Universiti Selangor untuk menyampaikan ucapan perasmian dan seterusnya merasmikan 21st Undergraduate Colloquium on Earth Sciences 2026. Dengan segala hormatnya, dipersilakan.
Thank you, Mr. Awang Nuraimi bin Awang Mat Yassim, for your warm words of welcome and encouragement. Ladies and gentlemen, we now arrive at the official opening ceremony of today's colloquium. It is a privilege to invite our guest of honor, Associate Professor Dr. Nur Shafiza, Industrial Linkage, University Selangor, to deliver the opening speech and to officiate the 21st Undergraduate Colloquium on Health Sciences UCSH 2026. Please welcome Associate Professor Dr. Nur Shafiza Ahmad Syukur.
Thank you to both Masters of Ceremony. Assalamualaikum warahmatullahi wabarakatuh and warm greetings to all participants, speakers, academic students and guests of honors of the 21st Undergraduate Colloquium of Health Sciences UCHS 2026, which proudly presented or organized by the Faculty of Health Sciences, University Selangor. This year's theme, Advancing Health Through Science, Safety and Sustainability, reflects the faculty's commitment for fostering a future healthcare workforce that is grounded in scientific excellence, dedicated to patient and community safety, and mindful of sustainable health practices. As healthcare challenges continue to evolve globally, the integration of research, innovation, and evidence-based decision-making remains essential in improving health outcomes and ensuring the well-being of present and future generations. So the Undergraduate Colloquium on Health Sciences has become a valued platform for nurturing scientific inquiry, enhancing communication skills, and of course, promoting academic excellence among our students. This colloquium is more than just a platform for presenting research. It is an opportunity for our students to share their ideas, learn from one another, and engage with experts from across the health sciences community. I really hope that this experience will not only strengthen their knowledge, but also build their confidence, sharpen their critical thinking, and inspire them to continue learning throughout their professional career. We at the Center for Research and Innovation Excellence, or we like to be known as SRI, strongly welcome and support initiatives such as this colloquium as they foster a vibrant research culture and encourage the dissemination of knowledge across disciplines. Research is not only about generating new knowledge, but also about sharing ideas, inspiring collaboration, inspiring others, and translating evidence into meaningful impact for society, which this event, like UCHS, provides an important platform for nurturing these values among our future researchers and healthcare professionals. This year, we are privileged to welcome two distinguished speakers who will share their expertise and insights with our participants. I would like to extend my sincere appreciation to Dr. Wong Li Hui, who will deliver a keynote presentation entitled Precision Hematology from Blood Smear to Molecular Diagnostics. Her presentation highlights the remarkable advancement in diagnostic science and the growing role of precision medicine in improving patient care. On the other hand, I would also like to express our gratitude to Dr. Rizky Novera Yanita for sharing her expertise in the field of public health, an area that remains fundamental in addressing population health challenges, promoting disease prevention, and strengthening community well-being. The themes presented by our invited speakers exemplify the interdisciplinary nature of health sciences, where laboratory innovation, clinical practice, and public health initiatives work together to improve healthcare delivery and outcomes. Their contributions will undoubtedly inspire our students to appreciate the importance of research and collaboration in advancing health at both individual and population levels. I would like to congratulate the organizing committee lecturers, organizing committee, the lecturers, and students whose dedication and hard work have made this event possible. Your commitment reflects the values of professionalism, teamwork, and academic excellence that the faculty strives to instill in our graduates. To all participants, I encourage you to actively engage in the discussion, ask related questions, argue if you may, throw some questions to your presenters, learn from the presentation, and embrace the opportunity to broaden your knowledge and perspectives. May this colloquium serve as a catalyst for future research, innovation, and meaningful contribution to the health sciences profession. I wish everyone fruitful and successful colloquium. With that, thank you.
Majlis makamkan setinggi-tinggi penghargaan kepada Yang Berbahagia Profesor Maya Dr. Nur Shafizah Ahmad Syukur atas ucapan rasmian serta kesediaan merasmikan Colloquium pada hari ini. Hadirin yang dihormati, sebelum kita meneruskan agenda seterusnya, marilah kita sama-sama menyaksikan tayangan multimedia UCSH tahun 2026. Dipersilakan.
Thank you, Associate Professor Dr. Nur Shafizah Ahmad Syukur, for your inspiring officiating address and for officially opening the 21st Undergraduate Colloquium on Health Sciences UCSH 2026. Distinguished guests, members of the organizing committee, ladies and gentlemen, before we continue with the next agenda, we invite you to enjoy a multimedia presentation of UCSH 2026.
Terima kasih atas tayangan yang telah dipersembahkan. Hadirin sekalian, kini kita beralih kepada acara seterusnya, iaitu sesi ucap tamak. Sebelum sesi dimulakan, kami ingin menjemput para hadirin yang mengikuti siaran secara langsung untuk mengimbas kod QR yang tertera bagi tujuan pendaftaran. Pautan untuk isi jel akan disediakan selepas penceramah kedua kita selesai menyampaikan ucapan beliau. Kami juga mengalu-alukan para hadirin untuk mengemukakan sebarang pertanyaan kepada para penceramah di ruang komen sepanjang sesi berlangsung. Soalan-soalan yang dipilih akan dikemukakan semasa sesi soal jawab selepas tamat kedua-dua ucap tamak.
Thank you for the multimedia presentation. Ladies and gentlemen, come to the keynote session. Before we begin the session, we would like to invite our audience to scan the QR code displayed for registration purpose. Please note that the e-certificate link will be released after the second speaker completes her presentation. We also welcome you to submit any questions for us throughout the session. Selected question will be addressed during the Q&A session after both keynote addresses conclude.
Kini, dengan sukacitanya, majlis memperkenalkan penceramah ucap tama pertama kita. Dr. Reski Dawera Yanita merupakan Wakil Rektor 1 di Institut Kesihatan dan Teknologi Al-Insyirah, Pekanbaru, Indonesia. Beliau akan menyampaikan ucap tama bertajuk NS Family Model as a Cadre Approach to Community Empowerment in Stunting Control in the Work Area of Rejosari Health Center, Pekanbaru. Dengan segala hormatnya, dipersilakan Dr. Rizky Novera Yanita untuk menyampaikan ucap tama beliau.
It is now my pleasure to introduce our first keynote speaker, Dr. Rizky Novera Yanita, Institute of Health and Technology Al-Insyirah, Pekanbaru, Indonesia, approach to community empowerment in stunting control in the work area of Rejosari Health Center, Pekanbaru. Please welcome Dr. Rizky Novera Yanita.
Okay, thank you very much, Master of Ceremony, Miss Benita, and Mr. Jefferson. Thank you. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning to all. I would like to begin by expressing my sincere gratitude and respect to Associate Professor Dr. Nur Sufiza Ahmad Sukor, Director of the Center for Research and Innovation in Enterprise, University Selangor, Associate Professor Dr. Megala Nalapan Maniam, Advisor of the 2021 Undergrad Colloquium on Health Science, my esteemed fellow speaker, Dr. Wong Lin Hui, as well as all faculty members, staff, and students of the Faculty of Health Science, University Selangor, who are joining us today via Facebook Live. It is a great honor and privilege for me to stand before you today as an invited speaker at the 21 Undergraduate Colloquium on Health Science 2026. On behalf of the Institut Kesehatan and Teknologi Al-Insyirah, Pekanbaru, Indonesia, I would like to thank the organizing committee for this generous invitation and for the trust pledge in my to share my work with such a distinguished academic community. My name is Rizky Novera Yanita, and this morning I have the pleasure of presenting my research title NS Family Model as a Cadre Approach to Community Empowerment in Stunting Control. This study reflects our collective effort to strengthen the role of community health cadres in addressing one of the most pressing public health challenges we face today, childhood stunting. I sincerely hope that the finding I shared this morning might offer meaningful insight and inspire further discussion, particularly among our future health professionals here at University Selangor. Once again, thank you for this wonderful opportunity. Without further delay, allow me to begin my presentation. That's it. Udah masuk PowerPoint-nya? Udah, lagi. Oke. Okay, Miss Benita, can you see my PowerPoint? My presentation? Okay. My title? Okay.
My title is Anas Family Model, a cadre approach to community empowerment in stunting control, working area of Rejo Sari Health Center, Pekanbaru. I'm collaboration research with my counselor in Al Insira Institute Health and Technology, Associate Professor Dr. Nurse Hajari Fayanti, SCAP and Biomed. Next. Oke, tak kenal maka tak sayang kalau kita cakap orang Melayu, tak kenal maka tak cinta pula. I born in Pekanbaru, Riau, 19 November. Education, midwifery in diploma program. This is my education, public health in bachelor program, environment health magister program, and the last environment science program doctor. Okay. The stunting challenge in Indonesia, impaired linear growth from prolonged inadequate nutrition and is national development priority. Disease definition, stunting is impaired linear growth in children caused by long-term inadequate nutrition intake, reflected in height for egg below standard. Direct cause, exclusive breastfeeding practice, infectious disease, dietary intake, and low birth weight. Indirect cause, parental education, parental occupation, and household economic status. Cadre involvement, Posyandu cadre knowledge of the five-step system is a critical, often overlooked factor. 30.8% national stunting prevalence in 2018, down from 37.2% in 2013, yet still far above the World Health Organization target of under 20%. Top 5 in Indonesia, ranked among the world's top 5 countries for stunting boom. 7.5 million children affected. Disease, Rejo Sari Health Center area continues to report stunting as a serious unsolved public health issue. Research aim and methodology, step to develop and implement the Anas family model is a cadre approach to community empowerment for stunting control. Number 1, literature review, examine prior work on stunting control, community empowerment, and the cadre role in public health. And 2, data collection, administer questionnaire to cadres, community members, and health workers in the Rejo Sari working area. My research. Thematic analysis, analyze data thematically to identify themes and patterns relevant. Build the Anas family model from the combined result of data analysis and literature. Next. Okay. Population and sampling, my research, I have 58 cadres. Total population of Posyandu cadres include in the study and 3 village sub-district within the Rejo Sari Health Center working area. Purposive sampling, sample were selected use purposive sampling based on defined criteria rather than random selection. Inclusion criteria, my respondent is cadre actively engaged in Posyandu activities, cadres with hands-on experience in stunting control effort. Okay, this is my result from unified data in VC table 1. Respondent classification under the Anas family model, 58 in Rejo Sari Health Center, is number 1, 81% nutrition. 47 of 58 respondents rated good, the strongest indicator overall. The 2, 79%, stunting status, 46 of 58 respondent classified as good. 76% mentoring. 44 of 58 respondent received good cadre monitoring. 24% is sanitation. 43 of 58 respondent the weakest of the 4 indicators. Okay, we see different results in table 2. Association between cadre mentoring and nutrition, stunting status, and sanitation. Number 1, nutrition. cross-tabulation with good mentoring, 44 per 58, 76% good mentoring and good calm. This is very significant. Number 2, stunting status, cross-tabulation with good mentoring, and the last, sanitation, cross-tabulation with good mentoring. This is the two variable not significant. Next. Okay. Discussion, cadre mentoring and nutrition. Most mother demonstrated good nutrition knowledge. There, 76%, consistent with a monthly senior high school education level that support either information processing. Finding aligned with Arnita 2020, where 72% of respondents saw good stunting knowledge. Draw contrast with lower knowledge result reported by Basuki and Uminingsi 2019. Good knowledge alone does not guarantee healthy behavior. Economic constraints can still limit the application of balanced lifestyle. Okay. Oh yeah. Discussion cadre knowledge and attitude. 79% of Posyandu cadres shows good knowledge of stunting. Knowledge is set by internal factor. They are age, education, experience, and external factor, occupation, environment, socioeconomy. Attitude finding, 25 of 58 cadres still show a negative attitude, links to low participation in research and capacity building training. Point 2, trained cadres with strong knowledge had attended more sessions, refresher training, stunting training, growth mentoring, and child growth chart record keeping. The point 3, comparable study found 55% negative attitude. This is Sai Kuswanti and Hairani Az-Zahra 2022, yet not significant link with attitude and stunting incident. The point of p-value 0.9. Point 4, consistent result, Dwi Ramadhani et al. 2025, likewise found no significant attitude. Stunting associate, the value, p-value 0.4. Next. The next variable discussion, environmental sanitation. 59% from 34 of 58 respondents rate sanitation good. The weakest score of the 4 indicator. Number 1, waste management is the weak point. Most households still burn rivers seen as faster than proper sorting and disposal. Environmental sanitation covers human waste disposal, clean water supply, waste disposal, wastewater management, and hygiene behavior. The 3 poor hygiene and sanitation condition rise to the risk of infection like diarrhea and respiratory illness, but likened to stunting. Sound household sanitation is foundational to family health and in stagnant household economic and social well-being. Okay, takeaway, what the ANAS family models tell us about career stunting control. Number 1, mentoring drives nutrition. Good career mentoring is strongly and significantly associated with good child nutrition. The value 0.0. Variable 2, sanitation need attention. At 59%, sanitation is the weakest link with burning habit remain widespread. Point 3, knowledge is strong. Action lags, 79% of cadre know stunting will, but knowledge alone does not guarantee behavior change. And point 4, training build capacity. Regular refresher training measurable improve both cadre knowledge and attitude. Oke, terima kasih. Thank you very much. That bring me to the end of my presentation. Before I close, allow me to briefly summarize the key point I have shared with you this morning. The ANAS family model demonstrates that empowering health volunteer, career structure mentoring, nutrition education, and knowledge building can play a significant role in community-based stunting control. Our findings show that good cadre mentoring is strongly associated with good nutritional outcome, while continuous training remains essential to strengthen good cadre knowledge and attitude. I hope this insight may serve as a meaningful contribution to the ongoing effort in public health and perhaps inspire future research among the students here at University Selangor. I truly hope that what I have shared today can be of benefit to all of you, and I look forward to any question or discussion you may have. Thank you very much for your kind attention. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih diucapkan kepada Dr. Rizky Novera Yanita atas pembicaraan yang amat berbana dan penuh inspirasi.
And inspire.
Kini kita akan membuka sesi soal jawab untuk soalan kepada Dr. Rizky Novera Yanita.
We will now begin the Q&A session featuring Dr. Rizky Novera Yanita. We welcome our audience.
Untuk sebarang pertanyaan, para hadirin sekalian boleh mengemukakan soalan di
Can you explain what makes knowledge different from standard from apa?
Okay, Dr. Rizky Novera Yanita,
Okay.
Yang ada di Jandu apa?
Iya. Saya boleh langsung answer ke? Atau saya komen kat komen kita? Mr. Jepson? Aku perbedaan standar lainnya gitu ya.
okay, we one question for Dr. Rizky. Can you explain what makes the ANAS family model different from the stunting program that are already being used in the community?
Okay, Miss Beneta, can I answer? Kayak tak dengar deh, masih enggak suaranya? Okay. Iya. Can I answer? Miss Beneta, Mr. Jepson?
Sure, Doctor.
Okay.
Yes, Doctor, sure.
Yes, ANAS Family Model ini fokus kepada boleh saya bahasa Indonesia dulu ya, nanti ditranslate sama asisten saya. Jadi ada pola asuh, ada nutrisi, ada asah atau memberikan pengetahuan kepada ibunya, dan juga sanitasi. Sudah.
This family model focus on parenting styles and imparting knowledge for the mothers of the children.
Okay, thank you,
Jadi
Dr.
kita
We
fokusnya
have
ada
second
4
question.
variabel.
After this
Iya.
project ends, how can the health volunteers continue using the ANAS family model to help?
Iya. Ini akan terus dipakai untuk dalam satu wilayah. Yuk.
It will continue to use for uh, one region of the cadre.
Jadi untuk fokus dalam seluruh wilayahnya itu sesuai dengan faktor yang terjadi dalam satu wilayah. Misalnya kita fokus kepada gizi balitanya. Jadi semuanya harus sejalan antara si anaknya, ibunya, lingkungannya, dan juga pengetahuan si ibunya. Itu yang harus diterapkan secara kontinu.
To maintain focus within the design area.
Terima kasih diucapkan kepada Dr. Rizky atas sesi soal jawab sebentar tadi. Hadirin sekalian, kita akan meneruskan sesi ucap pertama dengan penceramah kedua. Dr. Wong Lin Hui merupakan seorang pakar patologi klinikal dan Ketua Jabatan Patologi yang kini sedang berkhidmat di Hospital Seriaman 2. Beliau akan menyampaikan ucap pertama bertajuk Precision Hematology from Blood Smear to Molecular Diagnostic. Dengan segala hormatnya, dipersilakan.
Thank you once again to Dr. Novera Yanita for the Q&A session. Ladies and gentlemen, we shall now continue with our second keynote address, entitled Precision Hematology from Blood Smear to Molecular Diagnostic. Please welcome Dr. Wong Lin Hui.
Hello, testing. Can anyone hear me? Hello, testing. Testing. Can anyone hear me? I just want to check if you guys can hear me because I cannot hear. Hello, sound check. Can anyone hear me? Okay, good morning to distinguished chairpersons, respected members of the organizing committee, fellow colleagues, and most importantly, our dear students, the undergraduate students, and all participants. It is a great privilege and a pleasure to be here today at the 21st Undergraduate Colloquium on Health Sciences. I would like to thank the organizing committee for the kind invitation to share this session with all of you. So today's theme, I can see that it is advancing health through science, safety, and sustainability. Important role of innovation in improving patient care. At the same time, these innovations challenge us to ensure that healthcare remains safe, evidence-based, accessible, and sustainable for the future generations. So in this session, allow me to explore with you how hematology has evolved from conventional microscopy to advanced molecular techniques. So while highlighting the continuing importance of the peripheral blood smear in modern clinical practices, I hope this session will provide you with better understanding of how laboratory medicine contributes to the accurate diagnosis, patient safety, and better healthcare outcomes. With that, let us begin. So these are my contents for the introduction. So why hematology matters? For those of us maybe who are not familiar with the term hematology, it is the study of blood and blood disorders. It is also a specialized branch of medicine that focuses on the study, diagnosis, treatment, and prevention of blood-related disorders. So it plays an important role in the diagnosis of systemic disease because many, if not all, the systemic disease will at one point of the disease cause drop some hint in the hematologic context, be it anemia, leukocytosis, thrombocytopenia, or deranged coagulation profile in short, in the simplest term. So our clinical colleagues also depend on us for accurate and reliable laboratory results to assist them in their day-to-day clinical decision-making points to support them in their practice of evidence-based medicine. So the rapid advancement of technologies in the diagnostic technologies over the past few years have allowed all branches of hematology, all branches of pathology, not just the hematology, to play an important role, a more central role in supporting clinical management. So basically, our role in the laboratory medicine is to support clinical decision making by providing evidence-based medicine to give an objective disease evidence, and we bridges the primary, the care between the primary setting and the tertiary, more specialized setting. So this is just to show the evolution of the historical and molecular in the hematological diagnostic as we so on a journey to discover how the field of hematology has evolved from the analog morphology on the left side of the screen to the right side of the screen, the digital genomics. Before that, allow me to explain to you one real case scenario to illustrate my points. So this is a real life case which happened in our local setting. Allow me to present the case. This is a 24 years old gentleman, healthy, with no known prior medical illness, who came to the immediate our hospital's emergency department with the family members with the complaint of having headaches and vomiting for the past few days. So the initial full blood count was taken and it showed that there is a hemoglobin level of 8.6 gram per deciliter and a total white cell count of 736,000 per microliter, predominantly neutrophils, and platelet level of 219,000 per microliter. This shows that patient has moderate anemia, hyperleukocytosis, and a normal range of platelet count. So the emergency department actually called me on that day to request for an urgent peripheral blood film, short form at PBF, to rule out acute leukemia in view of the hyperleukocytosis. So just allow me to share with you one of the slides that I have seen using my machine. There is a crowding of the white cells in this flume, which is correspond to the hyperleukocytosis we seen in the peripheral blood indexes. So there are various stages of granulocytic maturation, as you can see here. There are bimodal peaks of neutrophils and myelocytes. There's also presence of 1% blast cells, lymphocytes, cytosis, eosinophilias, and basophilias. So this peripheral blood film, PBF, shows the features suggestive of myeloproliferative neoplasm favoring CML, chronic myeloid leukemia in chronic phase, because the blast count is less than 5%. So because of the symptoms that patient was complaining, having headaches and vomiting, so the emergency department also arranged for the CT brain for him, and unfortunately it reported that the patient has intracranial bleeding, ICB. So immediately from our district hospital, we refer this case to the tertiary hospital in Kuching for neurosurgical and hematological review and continuation of care on the same day. This will not be possible without the help of a simple peripheral blood film doing a morphological assessment of what's happening in the blood. So unfortunately, this is the level that we can provide, the care that we can provide. And for further more specialized care, we need to refer to a tertiary center. Unfortunately, even though the patient arrived at the tertiary center on the same day. He passed away the next day due to complication arising from the underlying medical illness, and thus unable to proceed with the diagnostic test, that is the BCR-ABL1 qualitative diagnostic analysis, unable to send this to the NIH, National Institutes of Health in Setia Alam, to confirm that this case is a case of CML, chronic myeloid leukemia. So this case, I hope that it can illustrate the importance of a simple hematological test, which is the PBF, to assist in the management in this patient. And even though we did our best to send the patient, to refer to the patient to the tertiary care, unfortunately, he succumbed to the complications. So let's move on to the main topic of today. So we have come a long way from analog counting to electronic pulses. So this, we are talking about the hematology analyzer. As you can see on the lower left corner, it is an analog counting. It is a Coulter model, which was introduced in 1953. So in 1953, Mr. Wallace Coulter, in 1953, he introduced this complete bird count analysis, a change from a highly variable, tedious, subjective process, because you have to count one by one. If in the olden days where you do this analysis, you have to count one by one. The introduction of this in analog counting was able to help the process of hematology test analysis to a rapid, reproducible process. So this helped to finally we are able to measure the form and the volume of the red cells, white cells, and the platelets in a more rapid pace and at a larger scales. So as you can see here, the hematological analyzer on the right lower corner is the newer version, the modern multimodal module particle counter. So how they function? Primarily on three core principles. The first will be the electrical impedance, as shown at the top area of the slide, where we use the Coulter principle to count and size the cells. Also, the second principle will be the laser flow cytometry, and the last will be the spectrophotometry to measure the hemoglobin. So let's look at the first principle. So in this principle, as you can see in the slide, we dilute the blood cell, and then we suspend them in the electrolyte solution, and we make them pass through one by one through a microscopic aperture, and as you can see illustrated in the slide here, between the two electrodes. So because blood cells, they are very poor electrical conductors, so each cells, when they pass through the apertures, they temporarily dislodge a volume of the conductive fluids. So this creates a measurable disruption of voltage pulse. As you can see, it was reflected at this graph on your top right corner. So as a result, the number of pulses equals to the total cell count, while the amplitude on the y-axis is the height of the pulse, where it is directly proportionate to your cell volumes. So this method is primarily used to analyze our red blood cell and platelet. Okay, so let's move on to the next slide. So as you can see here, we have changed from the era of morphology to the genomics era. Initially, in the 1970s, in the 19th centuries actually, the physicians such as Thomas Hodgkin and Rudolf Virchow, they use macroscopic and microscopic morphological descriptions to classify the hematological malignancies. In 1976, the French-American-British FAB classification, they formally characterized acute leukemias and myelodysplastic syndromes based heavily on morphology and cytochemical tests, using an arbitrary blast cut-off point of 30%. That was initial. Eventually, they changed to 20%. So this primary diagnostic was defined entirely on what can be seen. So we all know, maybe this is quite subjective. and thus lead to possible misinterpretation. And based on this morphology, sometimes the real case scenario in life may not follow what the textbook shows. So there are cases that I've heard before my time entering the pathological field. There will be time when in our local setting in my state, in Sarawak, before we have the advantage of having a more specialized test, there are cases where the pathologist cannot agree on the morphology. So this is very important in acute leukemia, because different type of leukemia will use different chemotherapy regime to treat the patient. If this is myeloid, we will start with cytarabine, or maybe if this is lymphoid leukemia, acute lymphoid leukemia, we will start with steroids. So morphological is very important because it will determine what type of treatment the patient will receive. And when pathologists cannot agree or come to a consensus of the morphology that we review, there will be cases where the patient has to be treated with both therapies. Actually, this is a case, real life case that I've heard, that the physician have to give both therapies because we cannot come to a conclusion, and we are waiting for a more diagnostic, a more conclusive confirmatory test. So because of that, patient have to receive 2 different chemotherapies just to make sure that we don't miss any. And fortunately, the patient survives and is now recovered well. So, but this is just to show, this case is just to share with you, to illustrate what is the difficulties when we only rely on morphology. Okay, so this slide is to show the technological milestones that we have achieved, starting from the morphology, going to the flow cytometry, immunohistochemistry, and now we are in the era of genomics, where we have cytogenetics, which include the karyotyping and FISH, which is the fluorescent in situ hybridization. It's also a test techniques. And now the latest, we are actually entering into the exciting era of NGS. So for flow cytometry, this is another interesting and powerful techniques that analyze the physical and chemical characteristics of cells and particles as they flow in a single fluid stream passing a laser. It can rapidly measure scattered light and fluorescence to quantify and sort distinct cell populations. So flow cytometry, which is now available in our state, is a very important tool to help when we cannot agree on the morphology, and also to confirm that the morphology is accurate. So next, we move on to the cytogenetics. So the cytogenetics is a newer molecular diagnosis where we do we add on things like PCR-based mutation detection, and it employs genetic markers that are significant, that can help to prognosticate patient, whether this is a good prognosis or bad prognosis, and to tailor personalized therapy for patient. So as you can see here, with the evolution of technologies, we also move from the morphological classification, the FAB classification that was introduced in 1970, 74, 75, and 6, to a new WHO hematolymphoid tumor classification, the 3rd and 4th edition, and the latest now is 5th edition, where they include or they integrate the genomic footprint that we have acquired over the years through research and through studies, and now we have come to the latest edition. So this is how much we have come to reach to the genomic eras. So every leap in the technologies help us actually change the diagnostic rule books if you follow the diagnostic criteria of different hematolymphoid tumors. And these molecular filters, in fact, overrides the microscope. In 2022, which is like 3 to 4 years ago, WHO actually published their latest edition, which is the 5th edition. And this 5th edition, together with the international consensus classification, ICC, they fundamentally shift the diagnostic from predominantly morphological base to a genetically focused module. In these modern frameworks, the presence of specific genetics anomalies can act as a distinct diagnostic entities, and sometimes overriding the traditional morphological requirements. For example, sometimes when we review the slides, there is not enough blast. Traditionally, it was the cutoff will be 20%. So physicians are left with deciding whether they need to start the treatment because they have not reached 20%. But there is evidence of leukemic clone cells. As you can see here, PML-RARA is a is a genetics marker for the diagnosis of our acute promyelocytic leukemia, APML. So sometimes when we have PML-RARA confirmed, the translocation confirmed, we can directly treat the patient without waiting for the disease to show up in 20%. Because in the marrow, in the factory, the disease is already there. So instead of relying on the traditional morphological interpretation and the blast cutoff of 20%, with PML-RARA fusion, we can start treatment. So this is the changes that was brought by the latest WHO 5th edition. So diagnostics are able to move towards targeted therapies, for example, tyrosine kinase inhibitors, TKIs, which is a very life-changing treatment for CML patient, which is the case that I introduced to you previously. If this 24 years old gentleman able to survive the intracranial bleed, his prospect, his lifespan, the prognosis is actually very bright. It's very good because with the introduction of TKIs, we now manage to control CMLs so that the CML patients can live the life with like normal individual without TKI, without CML, sorry. So the other medication is like targeted therapies include this venetoclax. It is a BCL2 inhibitors. These are targeted therapies, very expensive but effective. So as well as with the genomics, it brings us to minimal residual disease or measurable residual disease monitoring, where we can keep a tight supervision of the patient, because previously we depend on our morphology, how many percent of blast, 1%, 2%, 3%. With MRD, we can go as low as 0.01. That is submicroscopic level, which beyond human ability. So with these technologies, these MRD monitorings, we can give a better prognosis, a closer monitoring of disease, especially in hematological malignancy context, and give a higher overall survival. However, unfortunately, not every country is able to afford these diagnostic criteria if we include the genomics diagnosis. When WHO said that to diagnose this CML, you need to have Philadelphia chromosome proven by cytogenetics, or you can have BCL-ABL molecular diagnosis. If some of the countries from the lower and middle income countries, they are unable to afford these more high-end technologies to diagnose, this can cause the delay in turnaround time. Because without a diagnosis that is internationally agreed upon, the criteria, we cannot diagnose. Without diagnosis, we cannot start treatment. So unfortunately, patient is the one who bear the brunt of this problem. So the treatment may not be able to start, and we miss the golden time to diagnose the patient because we are unable to fit the definition of the disease. So this is the paradox of our precision hematology era. As you can see here, the low and middle income reality, the diagnostic gaps, they might not have enough pathologies to start the service, to diagnose, to give the evidence that the physicians require to diagnose the patient and to start treatment. As you can see here, sometimes the TAT can be much more longer in the lower and middle income country compared to the higher income country. And in Malaysia healthcare context, we are very fortunate because we have a very mature laboratory system, the pathology services. We employ a tiered laboratory system. For example, in my case, I'm from a district hospital, and we were sent to the regional labs. For example, in this case, for the CML, let's say in this, let's go back to the case. For example, if let's say this patient survived, and from the district hospital, the physician referred them to the hematologist in the regional center, which is in Kuching, in the context of Sarawak. When the patient is referred to the Sarawak General Hospital SGH in Kuching, so they will receive very good hematological care because the clinical hematologists are there. so they can start treatments for this patient, TKI, and they can come back to the district to continue with the medication, to collect the medication from the district hospitals. And the reference center is also very important because in Sarawak, we still have no access to the cytogenetics or moleculars. So we rely on the reference centers in KLs, in Selangor. For example, we have to send the BCR, ABL qualitative molecular diagnosis to IMR, Institute of Medical Research, or the NIH in Setia Alam in Selangor. So all this plays a role, even though, which is why it is very important that we have this tiered laboratory system, whereby even if in a remote area in a district hospital where you have a patient that needs a diagnosis and you need the genomics characteristics of this disease to fit the criteria set by the WHO, we have avenue to send to West Malaysia, to IMR, to NIH, so that we can get a diagnosis, so we can start treatment for this patient. So this is a efficient sample referral system that is already established in in Malaysia. So I think for us, we are truly blessed with this type of mature and efficient system. However, it comes with its challenges with resource limitation, workforce gaps. So I will not elaborate on this. But all these challenges can actually, in fact, present opportunities through digital morphologies, digital pathologies, and also AI integrations to help us to overcome the challenges that we face, especially in a more remote area, district hospitals. So in fact, digital pathology has already begun in the in our referral center, which is in Kuching, the Sarawak General Hospital, whereby they will help to process the slides, and they will process the slides digitally for us and then upload in the system, so we can also diagnose without waiting for the slide to arrive because of the geographical challenges in our local setting in Sarawak. So this is just a brief introduction to what we are facing here and what to put into the Malaysian healthcare context. Next is the global disparity matrix. As you can see, in the higher income countries, the NGS, the cytogenetics, moleculars, these are all routine. Whereas in our center, in the lower middle income countries, they rely heavily on basic morphology and clinical assessment. For example, in my setting, we are actually in the middle to high, Asia is classified as such. But in district hospital, we still face significant challenges to set up our own labs. So prioritized will be in the referral centers. So for me, in a district hospital setting, I rely a lot on basic morphology and clinical assessment, but with an opportunity to access the higher end diagnosis modality. So this is in Malaysia context. Also, for guideline adherence in the high income countries, they can fully comply with the WHO classification, the diagnostic criteria that was listed. But then in the lower and middle country, they struggle to even meet the basic standards because of lack of flow cytometry and cytogenetics, which in Malaysia, we are very fortunate to have both available. And even in Sarawak, we have flow cytometries, and we are looking into establishing our cytogenetics lab to start this service. And to translate into a clinical context, the 4-year AML is acute myeloid leukemia. The overall survival in pediatric populations, it can go as high as 76% in a high-income country such as Germany, and it can go as low as 10% in a lower to middle-income country. So this is the consequences that is very sad because of the gap in the global equity. And to bridge the global diagnostic chasm, these are the recommendations as I have read in the articles, to produce guideline that is more aware of the local context, especially in the lower and middle income country, and to invest in sustainable high impact point of care tools. For example, Gene Expert. So if you can, if you remember, the molecular, initially the PCR techniques is a very labor intensive and high cost. But with the introduction of Gene Expert, even in a district hospital like mine here in Sri Aman, we were able to have this Gene Expert platform. not in the hematological field, but in microbiology in diagnosing TB, tuberculosis. But that shows that a sustainable high impact point of care tools can actually be developed maybe by one of the students here who have interest in who has interest in looking into a more sustainable technologies in future. So I put that to you, to all the audience here. So maybe if you are interested, you can look into this area, and also a sustained human capital. So just rather than just donating the equipments to the low and middle income countries, we help with long-term funding for to train the pathologists and to set up the lab to help with the development of our in hematology and also in the whole pathology field. Okay, so in short, technology should serve the context and not dictate it. So the true measure of our medical progress is not just relying on the revolving power of our genomic sequences. It's our ability to ensure that everyone in our global setting are able to access the technologies. So precision medicine without practical accessibility is really a paradox lah. Okay, so what is just a brief precision hematology in this context? It is the integration of morphology, which is the traditional way of diagnosing, moving towards integrate with the higher ends test techniques. So, for example, immunophenotyping and molecular diagnostics, and towards this precision medicine, especially in the context of hematology, we can move towards individualized patient diagnosis, which will improve patients' safety, improve diagnostic accuracy, and also utilize smart tests versus the over usage. But I'm not going into that today. So, okay, this is actually my last slide. These are my references. I would like to thank the organizing committee for organizing such a wonderful undergraduate colloquium, which is impressive. And I also like to thank my hospital director for allowing me to join this session today to share a little bit of my knowledge. And also I would like to thank all the patients that has indirectly or directly participated and inspired us to advance healthcare through science, through compassion and lifelong learning. With that, I thank you for your attention, and I wish you a productive and inspiring colloquium, and I'm happy to take any question from the floor. Thank you very much.
Terima kasih diucapkan kepada Dr. Wong Lin Hui atas perkongsian ilmu dan pengalaman yang begitu bermanfaat. Hadirin yang dihormati, kini kita memasuki sesi soal jawab bersama Dr. Wong Lin Hui. Soalan-soalan yang akan dibincangkan adalah soalan yang diterima daripada ruangan komen sepanjang sesi ucap tama berlangsung.
Thank you, Dr. Wong Lin Hui, for sharing your expertise and valuable insights with us today. Ladies and gentlemen, we will now begin the Q&A session featuring Dr. Wong Lin Hui. The questions to be addressed have been selected from those submitted through the comment section during the keynote presentation.
Oh, wow, that's a very good question. Thank you for the question. For this, in the era of next generation sequencing NGS,
so the first question
about Malaysia.
In the era of next generation sequencing, what is the continuing role of peripheral blood smear examination? Second one, from your experience, what are the most common pre-analytical or results?
Okay, thank you for the question, and I'm happy to take the question. So without further ado, I will be answering this from the perspective of a clinical pathologist specialized in hematology from a district hospital in the public hospital system. So for us, the peripheral blood smear examination is still very important because it serves as a screening tools to screen the patients to make sure that we do not unnecessarily refer patient sample to a more expensive diagnostics modality such as the NGS. As you, if I remember correctly, in the hospital setting, in the public health system, when I attached in Hospital Tunku Azizah, where we have the NGS available, one test can go up to few thousands, up to 10,000. So that test for now in this current setting is still very expensive. So they are very selective of the patient. So peripheral blood smear, for example, in the case that I shared just now, so let's say if a patient comes, let's say with hyperleukocytosis, more than 100. So it is my responsibility to do a peripheral blood smear to examine the slides to make sure that this is a case of true leukemia. It could be it acute leukemia or chronic leukemia, because there are instances like leukemia reaction. Leukemia reaction may occur, for example, in the presence of a solid malignancy. For example, let's say a patient has breast cancer and the body is trying to respond to the cancer that is present by trying to fight the cancer that is there. So we do see leukemia reaction, whereby majority of the white blood cells will be neutrophils and they are in the mature form. They are not the blast. So with the simple peripheral blood smear, safely conclude that, oh, this patient most likely is leukemia reaction. Let's just follow up the patient with peripheral blood smear, and we do not need to send for the more expensive test. And my experience, the most common pre-analyticals from a district point of view, to be honest, based on the data, pre-analyticals factors comprise up to 60 to 80% factors that can compromise whatever diagnosis, not just in molecular setting. Most of the reports will quote 60 to 80% pre-analytical reasons. So in our clinical diagnosis, clinical pathology setting in a district hospital, to send a test to the nearest Kuching Central General Hospital, which is 2.5 hours away, about 200 kilometers away. For example, use this the case that real life case that I shared just now. We have to make sure that the sample is sent, the sample stability is met, and if the cold chain is required, we have to maintain the cold chain to make sure that we don't compromise the molecular diagnostics. We have to make sure that for that 2.5 hours, or maybe 3 to 4 if there's rain or there's unexpected accidents on the road. So we have to make sure that during the transport process, we can maintain the temperature, maintain the stability of the sample. So that is the pre-analytical part. And that is just within Sarawak. Let's say if we need to send to IMR, NIH in Setia Alam, that will be another challenge, because we have to make sure that from Sri Aman to KL, that will take up to 3 or 4 days of transit time. So we have to make sure that the sample that we send is the freshest as possible, so that we can reach the destination with a correct temperature, with the right stability for the sample, so that we don't compromise the diagnostic results. So if you ask me, the most challenging part will be the logistical part, and the rest we can communicate with the clinician to give us the fresh samples. And for the analytical part, I think the one that I mentioned earlier, the temperature, the sample stabilities, the correct tubes and everything, these are the things that we need to make sure. And of course, some of things like clotted samples, hemolyzed samples, before we send off, we already reject in our lab, because we don't want to waste the resources to send off to KL, to Selangor, just to get rejected at the referral center. We will reject at our setting itself. So I was say, okay, I hope I answer your question.
Terima kasih kepada Dr. Wong Indi Hui atas jawapan pada soalan sebentar tadi. Penghargaan juga kepada para hadirin.
Okay, thank you, Doctor. For considering that advanced technologies such as molecular testing and flow cytometry are costly, how can hospitals, particularly those in resource-limited areas, balance the
Hello, testing. Can you hear me? Sorry, I cannot hear you, but I'm happy to take the question. For this, I think one of my slides, we talk about the tiered laboratory system. So exactly that is how the healthcare system in Sarawak and in Malaysia in general plan their services. As you mentioned, the advanced technologies such as molecular testing, flow cytometries, all these tests are not available at our local setting in district hospital. They are costly, and if to set up, I would expect years and years to come. So it is not readily available. But we have a very good sample referral system, which is something that is available in our KKM setting and public hospital healthcare system, whereby, for example, in my case, district hospital, let's go back to the case. Like for example, in this case, let's say it's not a CML case, let's say it's an acute leukemia cases, which we have encountered actually, and we refer the patient out. So for that, some of the cases will require flow cytometry. So we will send the sample. We have the avenue to send the sample to SGH, Sarawak General Hospital in Kuching, to run the flow cytometry. And for the cytogenetics, for example, the karyotypings, the fish, and also the common molecular genetics mutations that we have to send to HKL or IMR accordingly. Usually we send to IMR. So we have the opportunity, and we have the system available that we can send, we can outsource, we can refer them to a more specialized center. So that is how our model works, whereby we are not in a rush to set up all the high-end technologies, because it's very costly at all clinical settings, at all hospitals, even including districts. But we prioritize some of the referral areas. For example, in Sabah, Sarawak, sometimes we usually will send to IMR, HKL, HTA. And for the northern part of the West Malaysia, sometimes they will send to the local setting, like southern, northern, and central region. That's how we divide our service actually. So they will have their own referral center. For example, let's say the flow cytometry. With the establishment of flow cytometry in the past, I think 5 years, I think it's also very new in our Sarawak local setting. All the hospital in Sarawak is able to send. Initially, I think last year they only served the southern region, which includes Sri Aman. And this year they opened the service for Sibu, Miri, and Bintulu. So these are the this geographical challenge should not limit us from providing the service. Yeah, for me, the resource limited area, what we do is we connect them to the referral center to allow them to have the ways to send their samples to access this. So I think so far what we are doing is quite good, but of course we have to continue developing ourselves and improve ourselves in this respect. I hope I answer your question.
Terima kasih kepada Dr. Wong atas jawapan tadi. Terima kasih juga kepada kedua-dua penceramah atas kesediaan berkongsi pandangan dan menjawab setiap persoalan yang dikemukakan. Penghargaan juga kepada para hadirin atas soalan-soalan yang bernas dan penyertaan aktif sepanjang sesi ini.
Appreciation to both keynote speakers and Dr. Wong Lin Hui for your thoughtful responses and valuable insights. We also thank our audience for the
Hadirin sekalian, majlis diteruskan dengan sesi pembentangan lisan yang menampilkan hasil penyelidikan daripada pelajar Fakulti Sains Kesihatan. Pembentang pertama ialah saudari Siti Asmah binti Parmin dengan penelitian bertajuk Comparative Analysis of Total Bilirubin Using Open Source and Closed Source Calibration Bilirubinometer versus the Calorimetry Method at Klinik Kesihatan Simpang Renggam. Dengan segala hormatnya, dipersilakan saudari Siti Asmah binti Parmin untuk memulakan pembentangan beliau.
Ladies and gentlemen, we should now continue with the oral presentation session featuring research total bilirubin using open source and closed source calibration.
Thank you, Jefferson and Benita. Hi, everyone. Welcome to today's knowledge sharing session. A big thank you to those joining us on live Facebook and YouTube. My name is Siti Asmah Parmin, and I am like to share my finding from a study that is very close to the heart of medicine and community health. We are familiar with neonatal jaundice, right? Or also known baby jaundice. It is a very common condition, but one that requires extremely careful and precise management. Today, I will be presenting my thesis titled Comparative Analysis of Total Bilirubin Using Open Source and Closed Source Bilirubinometer versus the Calorimetry Method in Klinik Kesihatan Simpang Renggam. Neonatal hyperbilirubinemia is a common clinical condition caused by elevated bilirubin level. Accurate and timely measurement is critical to prevent serious complications such as acute bilirubin encephalopathy and kernicterus. Point of care bilirubinometer are widely used in primary healthcare, but their accuracy depends on the calibration system used, especially open source versus closed source configuration. My research objective is to compare analytical performance of open source and closed source bilirubinometer in measuring total bilirubin level among neonates at Klinik Kesihatan Simpang Renggam and to determine if both systems are clinically interchangeable based on precision, linearity, carryover, and method comparison study. The main objective of this study is to evaluate the analytical performance of an open source bilirubinometer and determine its clinical interchangeability with a closed source system based on precision, linearity, carryover, and method comparison. The primary problem is the lack of standardized comparison between these two calibration systems in primary care setting. Measurement discrepancy may lead to diagnostic error, potentially delaying necessary treatment for neonatal jaundice. For calibration gap, no standard comparison between open source and closed source bilirubinometer calibration system at primary care level. And clinical risk is inaccurate bilirubin reading may result in misdiagnosis or unnecessary referral, affecting neonatal outcome. Bilirubin is measured via calorimetry, which is known as gold standard, or direct spectrophotometry in bilirubinometers. Open source system use independent manufacturer calibrator, while closed source system use proprietary material from the instrument manufacturer. Previous studies show potential discrepancies between this approach. Open source system use independently manufactured calibration, allow flexibility in calibration material selection, lower cost but require rigorous verification. Meanwhile, closed source system use proprietary calibrator from the manufacturer, ensure testability but a higher cost, limited to manufacturer supply material only. The study aligned with UN Sustainable Development Goal SDG 3, good health and well-being, and SDG 9, industry, innovation and infrastructure, and Malaysia Madani Principle. It addressed the need of cost-effective, accurate diagnosis tool in resource-limited primary healthcare setting. SDG 3 and 9 promote accessibility healthcare and innovation in diagnostic technology for neonatal screening at primary care level. Meanwhile, Madani support Malaysian vision for sustainable, equitable healthcare through cost-effective point of care testing solution. This study apply a prospective comparative cross-sectional laboratory base design conduct at Klinik Kesihatan Semparenggam. A total of 40 neonatal capillary blood specimens were collected during routine jaundice screening. Analytical verification was performed according to Clinical and Laboratory Standard Institute CLSI guideline, utilizing passing bar block regression and blind almond agreement analysis. Analytical verification was performed on both open source and closed source bilirubinometer following CLSI guideline. Three key parameters were assessed: precision, linearity, and carryover to ensure measurement reliability. Precision within run precision assessment at low and high level. Percent coefficient variation, also known as CV, is 4.59% for low level and 1.65% at high level, which is meet the acceptable criteria less than 5%. Linearity assess a cost concentration range R² equal to 0.997, confirming excellent linear response for both systems. And carryover assessment show 0.00% carryover, indicating no sample to sample contamination between measurement. This result has been right in the table. Okay, this is a precision table. Okay, for the parameter is we are measure precision, percent of coefficient variation CV, linearity R², and carryover. In performance result, precision as a state 4.59% for low level and 1.65% for high level, which is past the target limit of less than 5%. Meanwhile, for linearity, performance result is 0.997 and the target limit is more than 0.99. The carryover is 0.00%, and the target limit actually is less than 0.01%, which is those three parameters, precision, linearity, carryover, is passed with successful. Within run precision, one assessment at low 4.2 milligram per deciliter and high 15.8 milligram per deciliter bilirubin level. The open source bilirubinometer demonstrates percent coefficient variation of 4.59%, which is for low level, and 1.65% for high level, both meeting the acceptable criteria of less 5%. This confirms the system produce consistent and reproducible result across the clinical relevant. Passing Bardock regression analysis reveal a very strong correlation, which is R equal to 0.999 between the two systems, with a regression equation of closed source reading 1.012 times 2 open source reading minus plus 0.0285 milligram per deciliter. Passing Bardock regression analysis show excellent correlation between open source and closed source bilirubinometer, with regression equation y equal to 0.992x plus 0.0285. The slope of 0.992 close to 1 and intercept positive 0.0285 close to 0 indicate no significant proportional or constant bias between these two machines. Result blind almond plot. Blind almond analysis reveal a mean of bias 0.02 milligram per deciliter between open source and closed source bilirubinometer, with limit of agreement LOA within clinically acceptable range. This minimal bias confirm that both systems can be used interchangeable without significant measurement discrepancy. The narrow limit of agreement indicate consistent performance across the entire measurement range, supporting the reliability of the open source system for routine neonatal bilirubin screening in primary healthcare setting. This is the blind almond agreement plot, is illustrating the mean bias and limit of agreement between open source and closed source bilirubinometer. Method comparison between open source and closed source bilirubinometer show excellent correlation. R equal to 0.99 with regression equation y equal to 0.09x plus 0.0285. Blind element analysis reveal minimal bias of 0.02 milligram per deciliter with narrow limits of agreement, confirming clinical interchangeability. Blind element plot ni kita panggil dia sebagai different plot, which is digunakan untuk melihat taburan perbezaan antara dua kaedah secara visual bagi mengenal pasti sama ada bias berlaku secara konsisten atau bergantung kepada kepekatan analyte. In conclusion, the open source calibration bilirubinometer serve as a reliable, accurate and cost-effective alternative for neonatal hyperbilirubinemia surveillance in primary healthcare setting. That concludes my presentation. Thank you for your kind attention.
Terima kasih diucapkan kepada saudari Siti Asmah binti Parmin atas pembentangan yang telah disampaikan. Seterusnya, majlis menjemput saudara Tasha Raden Krishnan untuk membentangkan pendidikan beliau yang bertajuk Relationship between Occupational Task Performance and Lower Back Pain among Sanitary Unit Worker in Municipal Council of Alor Gajah, Melaka. Dengan segala hormatnya, dipersilakan.
Thank you, Siti Asma binti Parmin, for your informative presentation. Our next presenter is Tasha Radin Krishnan, who will present his research entitled Please welcome Tasha Radin Krishnan.
A very good morning, everyone. My name is Tasharadhan Krishnan, final year student from Bachelor of Occupational Safety and Health from University Selangor. Today, I will be presenting my research entitled Relationship between Occupational Task Performance and Lower Back Pain among Sanitary Unit Workers in Municipal Council of Alor Gajah, Melaka. So first part is introduction. Lower back pain is one of the most common musculoskeletal disorders among workers, especially those involved in physically demanding jobs. Sanitary unit workers perform daily tasks such as lifting heavy waste beams, bending, prolonged standing, repetitive movements, and manual handling. These work activities place considerable stress on lower back and may affect their ability to perform occupational tasks efficiently. Although many studies have investigated lower back pain among industrial workers, there is limited research focusing specifically on sanitary unit workers in Malaysian Municipal Council. Therefore, this study was conducted to examine the relationship between occupational task performance and lower back pain among sanitary unit workers in Municipal Council of Alor Gajah, Melaka. Okay, next we move on to objective. This study has three research objectives. First is to determine the level of occupational task performance among sanitary unit workers. Second is to determine the level of lower back pain experienced by the workers. And third one is to examine the relationship between occupational task performance and lower back pain among sanitary unit workers. Okay, next is methodology. This study employed a quantitative cross-sectional research design. The study was conducted among 30 sanitary unit workers from the Municipal Council of Alor Gajah using purposive sampling. Data were collected using a Google form questionnaire. The questionnaire consisted of 4 sections. Section A collected demographic information. Section B measured occupational task performance using the NASA TLX questionnaire. And Section C assessed lower back pain using Oswestry Disability Index ODI. And finally, the collected data were analyzed using SPSS version 30. Descriptive statistics were used to determine the level of occupational task performance and lower back pain, while Pearson correlation was used to examine the relationship between the two variables. Okay, next we move on to results and discussion. Result 1 is demographic information. This slide presents the characteristic of 30 respondents, including age, gender, years of working experience, and other relevant demographic information. These demographic data provide a better understanding of the respondents involved in this study before analyzing the main research variables. So for results 2 is about occupational task performance. For low workload is 0 until 20, so there is no results. So for moderate workload is 21 until 60. So 3 respondents experience moderate workload, and for high workload 27 respondents experience the high workload. So very high workload there is no results. So for the occupational task performance, the results showed the majority of respondents experience a high occupational workload. Their daily work Their daily work involves repetitive lifting, bending, prolonged standing, and waste collection activities, all of which require considerable physical effort. These physically demanding tasks may increase fatigue, reduce work efficiency, and place greater physical stress on the workers. These findings are also consistent with previous studies conducted among sanitation workers. So results 3 is about lower back pain. So for minimal disability, there are 7 workers. So for moderate disability, 18 workers, and severe disability is about 5 workers. So for the discussion part, most respondents experience moderate lower back pain. Repetitive movements, manual handling, and awkward postures may contribute to back pain. Lower back pain can limit physical function and affect daily work activities. And findings support previous research on musculoskeletal disorders among sanitation workers. And next one is the relationship between occupational task performance and lower back pain. So this table shows for the NASA TLX scale, R value is negative 0.820 and P value is 0.037. So for the ODI, R value is 1.0. So the Pearson correlation showed a strong and statistically significant negative relationship between occupational task performance and low back pain. Since the p-value is less than 0.05, the relationship is statistically significant. So this means that workers with greater occupational demands were more likely to experience increased lower back pain. So these findings suggest that improving workplace ergonomics, promoting proper lifting techniques, and implementing effective workload management may help reduce lower back pain and improve workers' well-being. So this is the final part, which is conclusion. In conclusion, the study successfully achieved all the research objective. The findings indicate that sanitary unit workers experience a high occupational workload and moderate lower back pain. Furthermore, there was a strong and statistically significant relationship between occupational task performance and lower back pain. Therefore, employers should implement ergonomic interventions, provide manual handling training, encourage proper lifting techniques, and establish occupational health programs to reduce the risk of lower back pain and improve workers' health, safety, and job performance. So that's all from me. Thank you for your attention.
Terima kasih ucapkan kepada saudara Tashara dan Krishnan atas pembentangan sebentar tadi. Hadirin yang dihormati, ini tibalah sesi soal jawab bagi kedua-dua pembentangan lisan yang telah disampaikan. Soalan-soalan yang dipilih daripada ruangan komen adalah daripada ruangan komen. Dengan itu, saya menyebut kembali kedua-dua pembentang untuk bersama dengan kita.
Thank you, Tashara and Krishnan, for your presentation. Ladies and gentlemen, we now come to the Q&A session for board oral board presenters to rejoin us for the discussion. Okay, for the first question is for Siti Asma. Do you think the choice between an open source and closed source bilirubin performance in routine
Thank you for the question. as Jen Garnison. Okay, the decision between an open source and closed source bilirubinometer involve balancing analytical with the operational realities of public health setting. Based on my thesis, analysis factor influence of the choice is analysis performance as the foundation. Before cost or sustainability can be considered, analytical performance must be the primary filter. Okay, the second thing is cost effectiveness and democratization of care. Cost effectiveness is critical driver for the sustainability of public health network. Proprietary closed source system often impose heavy financial burden through digital lock and mandatory service contract, which can hinder the sustainability of rural clinic. Rural clinic. Validate open source platform offer a strategy to democratic access to essential screening by removing these financial barriers. And then the third consideration is long-term sustainability in routine practice. Sustainability in routine clinical practice is ultimately driven by the integration of performance and accessibility. An open source system that require no recalibration during the study duration and maintain stability across clinical range suggests a high levels of robust engineering. This inherent reliability combined with lower operational cost make it a more sustainable choice for primary healthcare setting like KK Semparenggam. Okay, what I mean here is untuk sebab study ni berlaku di klinik kesihatan Semparenggam, which is one of the government facility. Okay, dia punya kriteria untuk kita terima sama ada mesin itu adalah baik atau tidak baik, dia lebih kepada satu faktor utamanya adalah cost, and then the second thing is adalah report itu sama ada dia boleh dipercayai atau tidak. Okay, so untuk jangka masa panjang, kita akan mengambil kira terutamanya kos lah. Okay, terutamanya kos. Untuk kalau nak ikutkan daripada segi bahan penggunaan, iaitu dia punya consumable things, the both mesin untuk open source dengan closed source adalah sama. Dia tak ada beza pun sebenarnya. Tapi dia membezakan dia adalah daripada segi dia punya calibration sahaja. So untuk calibration ni, ini yang menentukan sama ada mesin closed source dan open source tu dia require more extra cost atau tidak. So kalau macam contoh untuk closed source ni dia memerlukan daily calibration, tapi daily calibration dia bukanlah menggunakan manufacturer punya solution, dia lebih kepada blank solution sahajalah. Blank solution provided by manufacturer. And then untuk open source pula, dia tak perlukan calibration every day, dia tak perlukan daily calibration, tapi dia lebih kepada apabila diperlukan. So for example-nya kalau QC tu out ataupun mesin tu baru lepas PPM ataupun mesin tu baru dibaiki daripada kerosakan. So kalau ikutkan untuk jangka masa panjang untuk routine practice in public health, kedua-dua mesin ni adalah reliable, dipercayai dan boleh digunakan sebenarnya. Saya harap saya menjawab soalan awak. Terima kasih.
For the next question is for Tasha. The question is, among the intervention technique,
Okay, thank you
which
for the
do
question. By improving tools, equipment, and the work environment, workers can perform their task more safely and comfortably. This is not only decreases the risk of lower back pain, but also improve productivity, reduce fatigue, and enhance overall occupational task performance. Since it addresses the root cause of the problem, ergonomic intervention is the most effective long-term strategy.
Terima kasih kepada kedua-dua pembentang atas perkongsian dan penjelasan yang diberikan serta kepada semua peserta atas penglibatan aktif dalam sesi ini.
Thank you to board presenters for your presentation and thoughtful responses, and to everyone who participated by submitting questions.
Hadirin yang dihormati, dengan berakhirnya sesi pertanyaan dan soal jawab sebentar tadi, maka berakhirlah sudah 21st Undergraduate Colloquium of Health Sciences 2026. Bagi pihak Fakulti Sains Kesihatan Universiti Selangor dan jawatan kuasa penganjur, kami merakamkan setinggi-tinggi penghargaan kepada Yang Berbahagia Profesor Maknya Dr. Nur Shafizah Ahmad Syukur, para penceramah undangan Dr. Rizky Nabera Yanita dan Dr. Wong Lin Hui, para pembentang Saudari Siti Asmah binti Parmin dan Saudara Tasha Raden Krishnan, ahli jawatan kuasa serta semua peserta yang telah bersama-sama menjayakan kolloquium ini. Sesungguhnya, sokongan dan penyertaan yang diberikan amat bermakna dalam menjayakan kolloquium ini sebagai platform perkongsian ilmu, penyelidikan dan inovasi. Semoga segala ilmu dan pengalaman yang dikongsikan sepanjang program ini menjadi inspirasi kepada lebih banyak penyelidikan serta kerjasama pada masa akan datang. Dengan ini, berakhirlah 21st Undergraduate Colloquium on Health Sciences 2026. Terima kasih atas kesediaan bersama kami pada hari ini. Semoga kita berjumpa lagi dalam penganjuran UCSH akan datang. Sekian, terima kasih.
Guests, ladies and gentlemen, with the conclusion of today's presentations and to the end of the 21st Undergraduate Colloquium on Health Sciences UCSH 2026. On behalf of the Faculty of Department and Tasha Raden Krishnan, organizing committees, members, and everyone who participated in today's colloquium, your presence and participation have made today's colloquium a meaningful platform for academic exchange, research disseminations, and innovation. We hope 2026 officially comes to a close. Thank you for joining us today, and we will
keilmuan jadi budaya, kepakaran sendi kerjaya, ilmu dihayati sepanjang usia, amal jariah tunjang jasa, dipayungi langit tanpa sempadan, bumi subur darul ihsan, disinari surya alam Tuhan yang esa, dibuai bayu ilmu peradaban. UNICEF kaulah sinar bestari, pancaran ilmu serta amali, mengisi minda pengasuh budi, pelopor utama insan misali. Kau umpama pohon nan rimbun, tumbuh subur teguh beruntun, jati diri hidup berukun, tahan uji turun temurun. UNICEF kaulah sinar bestari, pancaran ilmu serta amali, pengisi minda pengasuh budi, pelopor utama